Good evening. Welcome to our 5th virtual community town hall on COVID-19. I'm Xavier Richardson, the Senior Vice President and Chief Development Officer of Mary Washington Healthcare. For well over 120 years, Mary Washington Healthcare has been the sole nonprofit healthcare provider and hospital system in our community. As such, we're firmly committed to ensuring that we fulfill our mission of improving the health of the people in the communities we serve. One of our goals is to keep our community well informed on health-related issues that impact our residents. To that end, we're hosting this evening's town hall featuring a panel of our internal Mary Washington Healthcare experts on COVID-19 who will provide you an update on the pandemic with a special emphasis on its impact on our greater community. You will have an opportunity to submit questions to the panel throughout the program. At this time, I will turn the program over to Lisa Henry, Mary Washington Healthcare's Corporate Director of Marketing and Communications, to introduce our panelists.
Thank you, Xavier. Tonight we have with us Dr. Mike McDermott, President and CEO, Dr. Chris Newman, Chief Medical Officer and Chief Operating Officer, and Eileen Dohmann, our Chief Nursing Officer. We're going to go ahead and start with Dr. McDermott.
Good evening, everybody, and thanks again for taking a little bit of time out of your evening to join us for our town halls. Like Xavier said, I can't believe this is our 5th town hall that we've had here with our community members. But we like getting together and sharing with our community everything we've seen in the past few weeks, and so we're going to do it again today. The first thing I'd like to share is some of the data from one of our internal dashboards that we are using as we are going through the COVID crisis. And so on this dashboard, it shows we currently have 17 patients who have tested positive for COVID-19 that we are caring for within our facilities at Mary Washington Hospital and Stafford Hospital. We have 39 patients who we have hospitalized that we are considering patients under investigation. These are patients who have some symptomatology of COVID-19, but we're still awaiting test results to come back on them to know for sure whether or not they have COVID-19. We've discharged over 111 patients back home who we have treated as inpatients at Mary Washington and Stafford hospitals, and they've gotten better and they've gone home. We have had 14 deaths of patients who have had COVID-19 and have succumbed to the disease, and I know this week here in the United States, we passed that milestone of over 100,000 deaths from patients who have been affected by COVID-19. I think that's just a staggering number. It's hard for all of us to even get our heads around a number of that many deaths that can occur in such a really short time period here through the spring. This is a devastating disease. It can have very, very severe effects. It can be a very life-threatening disease, so please keep that in mind. The lines over to the right, the graphs show the yellow solid line is the number of patients we have in our facilities on every given day, going all the way back to from the beginning of March until now. And you can see for the last 6 weeks, we've hovered somewhere between 15 to 25 patients on any given day who we've been caring for who have COVID-19 in our hospitals. The red line buried in there's a solid red line that you can see. That's the number of patients with COVID-19 that's in our intensive care unit on any given day. And you can see that really has been anywhere between 5 and 10 patients for the last several weeks. And so our inpatient COVID care has been relatively stable for about 6 weeks or so, with some fluctuations around those numbers. And so that's what we're seeing here locally. There is continued COVID-19 in our community. There are patients who are requiring hospital care, but because all of the tactics that we've taken with social distancing, wearing masks, all of the governor's orders, limiting indoor gatherings, all of those things have kept the prevalence of COVID-19 in our community well within our capacity to care for everybody that needs hospital care. And that is very, very good news. And I think it's why we've seen some pretty good statistical outcomes of the patients we have treated here at Mary Washington Healthcare. So thank you to everybody in the community for taking this so seriously here in our Fredericksburg region, keeping everything within our capacity to care for everybody. There is another graphic I wanted to share with everybody tonight. It's a piece of data I saw just this morning, and it comes from one of the electronic medical record vendors, Epic. And so they're able to see data from hospitals all around the country, and they know the typical volumes of tests that are occurring around the country. And so this graphic shows some of the screening tests that are done for cancer, colonoscopies, mammograms, cervical cancer screenings, pap smears. And there's a typical volume that's seen daily across the United States, and that volume you can see has been consistent for years. But way over to the right side of the graph is the volume of those screening tests in March and April. And you can see how none of that screening has been happening here through the COVID crisis. And so some of that is understandable as we entered the crisis, but a significant drop off in screenings like that can have significant downstream negative effects, delayed effects from delaying that screening. So now that we're here, we're within our capacity to care for everybody who has COVID. Our healthcare facilities are back open. They're safe. We can care for everybody who needs healthcare services. I think it's important that everybody recognize if you have healthcare needs, please have them cared for. We are open, available to care in a very safe manner. We don't want these downstream, delayed, worse health outcomes. So please come and get your care if you need to have care to make sure you have a better health outcome. And so I just wanted to share that graphic with you. I thought it was very interesting. We need that screening graphic to get back to normal very, very quickly for everybody's improved health outcomes in the future.
Well, wasn't that so alarming to see that today? Because we know the earlier that we can detect, particularly cancer, the best chances that somebody has for a full recovery.
That's right.
And so that early detection can only happen by those screening mammograms, those screening colonoscopies and pap smears. To see them not happening, there's people out there that probably have an early cancer that may be going without being detected, and that by the time it is, time has gone by and time is not on your side with that kind of a diagnosis. So it is alarming to think about, as you mentioned, Mike, that the serious health complications that could come from this because we're not doing the early screening for early intervention.
Yeah, another thing I know that data is coming out on is the immunizations that are being delayed in children. And so the delayed immunizations in that population can lead to spreads of viruses that we typically don't consider our children to be even susceptible to because they've been immunized. So we need to make sure that we get our children immunized against those other viruses that can also be very, very deadly and have very, very severe illnesses associated with them. And so we need to make sure that we get these healthcare services that keep us all healthier long term.
And we continue to see reductions in people presenting for emergent and urgent situations that we've talked about the last couple times as well. Heart attacks, strokes, seeing increased deaths at home. So all of this is very, very important. And delaying care because of the concerns of COVID can lead to much more catastrophic downstream effects.
Yeah.
Thank you. And Eileen, can you talk to us a little bit about those services that people can seek here at Mary Washington Healthcare and the ways that they can seek that care?
Everything's open. So all of our services are open. All of them are accessible, and all of them are taking into consideration the precautions and things we need to do to keep you safe and to keep our associates safe. So we've got the tools that we need as far as the supplies and the PPE. We have our staff that is educated on what's the best thing to do to keep themselves safe as well as to keep you safe. And we have available slots for all of our services for people to be able to be seen, whether that's in the offices or in procedural areas, or even telehealth for many of our physician services and doctor's office visits. So all you really need to do is call your physician to schedule that appointment. And if you don't have a physician, then please call Mary Washington Healthcare HealthLink. The nurses there would be happy to direct you to physicians that are accepting new patients that can help get you screened. And I think we even have some same-day appointments that are available.
Same-day appointments. And for those that are, very concerned still or feel that they're very high risk, please use one of our telehealth services. And just to underscore the safety, this is a new virus, and at the beginning we were learning a lot about it and how to keep people safe, how it was transmitted. But one thing that we have all been following very, very closely is the number of our associates and our nurses and physicians who get tested positive and get transmission of this disease from on-the-job exposure. And I'm really proud to say in the last 7 weeks we've had no physicians or nurses or associates who've tested positive from an on-the-job exposure. Yeah. So, and these are people who are actively caring for COVID. So if you're coming for other care, you're immensely safe at this point.
Yeah, and there's a number of tactics that we're taking. You will be screened at our entrances, questionnaires. When you come in for services, we're going to make sure that it's safe that you're entering our facilities. And so there are just a host of factors that we are taking to make sure that you're receiving your health care in a safe manner.
If your doctor says that you need to have one of those screening tests or you need to have a procedure, that's going to be well planned out. We're planning those procedures out 2 weeks in advance so we can make sure that we have adequate time to do screening, to do a before procedure test, to make sure that you've got time to self-quarantine for an invasive procedure. And every step of the way, we're asking questions again to make sure that we don't have reason to think that you may have been exposed or may have COVID-19. And then when you come to us, we do that whole process again of doing that screening again. And so we feel very comfortable now that we know what to do to keep you safe and to keep our associates safe. And we're taking lots of extra steps. The limit to visitation is limiting the number of people that are coming into our buildings, but also making sure that for those patients that are with us for an inpatient stay, that they are able to have that significant someone be able to be with them and to visit them on a daily basis. So we've really tried to think of everything that we can that really maximizes your safety, our associate safety, but also your care, and making sure that you get the care that you need.
Thank you, Eileen. And one of the things we talked about before starting is the high level of anxiety that has occurred in our community and around the nation because of the early things we did to slow down the spread of the disease. And mental health crises is something that we're all concerned about. Can you talk a little bit about what's happening in that arena?
Sure, and we share those concerns. I think, as Chris mentioned, when the virus first started, it was very frightening because there was so much that we were learning each day. We talk a lot about that each day we were learning something new and we were changing things. But as Mike said, really we're now 6 weeks where things are pretty stable. It's still here, we're still seeing patients, but there is some stability to it. So we're feeling more and more confident and comfortable that we're knowing how to keep everybody safe. And so, then knowing that there's people in the community that have that fear, anxiety can be a very scary thing, and for someone that maybe has a behavioral health history, that anxiety can be catastrophic because it can be paralyzing. It can really interfere with your activities of daily living, prevent you from doing the things that allow you to take care of yourself. We also hear a lot about increased sales of alcohol across the country, and so raises the concern, are people using alcohol to help them cope with the anxiety or cope with the isolation? And all of these things are concerning for people's mental health. And so I encourage you that if you have a history of behavioral health or you have concerns about anxiety, and really the way to know that anxiety is a problem is when it interferes with your ability to do your usual activities of daily living. And so when you're not going out of the house because you're afraid to go out of the house, that you're paralyzed with that fear, is I encourage you to reach out to your primary care physician to seek care there. If you have a history of behavioral health, then your behavioral health provider is seeing them, your medications, making sure you're taking your medications as they're prescribed, getting those prescriptions refilled, and knowing that there are acute care behavioral health services that are available in the community. We're very fortunate that we have Snowden, our acute care hospital, that we're actually enlarging. We'll be expanding our beds at Snowden in July. We've continued with that construction because we know that that's a very significant need for our community. So your mental health health, your behavioral health needs are just as important as your physical health needs, and they can't be ignored. And the best way that you can take care of yourself is to seek care, is to seek out your primary care physician, seek out your behavioral health clinician and support, and follow your plan of care. It's the best thing that you can do to keep your behavioral health healthy.
And I think that question of uncertainty can cause anxiety, right? And
Sure.
there certainly has been a lot of uncertainty as we've encountered this COVID crisis. But we do know more and more every day, right? And more data comes out. So sometimes I think of, well, think of those things that you can control. And we do know now that there are some things, some tactics that you can take that can help limit your chances of getting COVID-19. And those things are limiting the amount of time that you're in places, right? Limiting the number of people that you're around, avoiding large gatherings of people in enclosed spaces, right? These are the sort of tactics that everybody can pay attention to those situations, try to avoid them, to try and take a little bit of control and limit their chances of coming down with COVID-19.
Well,
Yeah. Wearing a mask.
Mask.
Right, very, very important, right? And it's also a sign, we talk about this every time, a sign of caring for others, that if you might be in an asymptomatic period where you are contagious with COVID-19, wearing a mask limits the number of particles that you are shedding into any environment, and you might prevent others from getting it from you. So it's a sign of caring, it's a simple act. It's also a sign of showing everybody else that you care. So we encourage everybody to wear a mask. I know the governor just had a mandate for, and I think based on some of this data again, that hey, when you're inside places, in enclosed places, wearing a mask, if everybody's wearing a mask, it's going to limit, if somebody has the infection, the particles that are shed in that enclosed environment and limit any potential spread. So I think, we're supportive of the governor's orders. We have masking in all of our facilities at Mary Washington Healthcare for all of our associates and visitors and anybody that comes into our facilities. Masking can make a difference.
Thank you. And some of the things that have come up before the event that we wanted to be sure to include is clarity on the types of testing. What the 3 types of testing that we talk about internally, our customers don't quite understand the same: diagnostic, screening, and surveillance. And how do people get them? And Dr. Newman, maybe that could be your question.
Sure. So we've decided to break it down into 3 different definitions to make it simplify it. A lot of people are confused. Even people who are healthcare are confused on what test to get when and for what reason. So the first is really diagnostic testing, and that is the swab test, the PCR test, the genetic test. So that's the C where you see that they put the swab in the nose and they can test you. And that is for people who have active signs and symptoms of infection. You have a fever, you have a cough, you have some respiratory symptoms, and you want to make sure if you have the disease or not. That is the test that's appropriate to get for diagnosing. The same test, and we're calling this screening, is used to screen those certain individuals to see if you may be a carrier of the virus, if you may be shedding the virus. So we're screening everyone coming in for surgical procedures, scheduled surgical procedures, to ensure that they don't have the virus and bring it into our facilities, or even undergo a surgery when they may be in a weakened state and not know it. We're also using screening before sending individuals back to a skilled nursing facility, which is a very high risk, before sending them to our behavioral health hospital, which is another high risk situation for spreading. So we're using these screening tests, labor and delivery, moms-to-be, we are screening to ensure that they're safe when they come in for their delivery. And then the last category we're calling surveillance. And that is the antibody test that we're all hearing so much about. And that is never to be used for diagnosis. If you have symptoms of the disease, you should not be getting the antibody test. The antibody test tells us, have you had exposure to the disease, or did you have the virus in the past? And in fact, these antibodies often take 8 to 14 days to even form. So 8 to 14 days after you've had the illness, your body will start having antibodies to the point where we can detect them on these blood tests. And there's various accuracy of the blood tests, so you want to make sure that you're getting one of the FDA approved through emergency use authorization tests. We have one of those here through the company Ortho, but Roche, Abbott have some other approved, and this is through a blood test, and we look for antibodies. And if you have had COVID and you've recovered and you have these antibodies, you may be a candidate to give convalescent serum and donate that, which could be a potential life-saving treatment for somebody who's ill.
Thank you. We've actually had a question on convalescent plasma treatment. Have we done it here? How successful has it been, and who gets it?
We have been doing it here, and it has been successful. Of course, this is under a larger study through the Mayo Clinic, so the broad data on this research is not back yet. But locally, we've been seeing success. Anecdotally, across the country, we've been seeing success with this treatment. So we're very optimistic about it, and we have been using it for several weeks now. If you want to donate plasma, if you've had COVID and you've recovered, you want to contact the Red Cross. They're who are coordinating the process for donation. And they will screen you for antibodies and the level of antibodies to see if you're a candidate to donate. So I highly recommend that.
And somebody wanted clarification that you need a doctor's order to get any of these tests. Is that correct?
That's correct. You need a doctor's order, yes.
Thank you. One of the questions that came in is advice that we could provide to various ages. Is there different advice you'd give to different age groups based on their returning to work or starting into phase 1 of opening? Does it vary by age?
I believe the tactics are the same, right? We're all human beings, and so the tactics that we would all take, I think, are the same across all age groups. Now, there are certain individuals we know that if they get COVID-19, they're at risk for having a potentially tougher time and a worse outcome. And so those individuals, if you have other chronic conditions, severe hypertension, a bad heart disease, if you have those conditions, you should take special care at this time to try and avoid becoming infected with COVID-19. Really be extra careful. The tactics are the same though, right? It's wearing the masks, being aware of how much time you're spending in indoor environments, limiting your social contacts, keeping social distancing from others. All of the tactics are the same regardless of age group.
Yeah, I would say the vast majority of the fatalities have been those in advanced age or with these pre-existing conditions. But we have seen people, even here at Mary Washington, that have gotten very ill who've had none of that. Across the country, we've seen cases of children dying, younger people dying, healthcare employees dying. And we focus a lot on that mortality rate. I hear that over and over, and it's a catastrophic number, that 100,000. But 5 to 10 times that many people have been sick enough to be hospitalized, many who are in the ICU for long periods of time. So it's literally 5 to 10 times that many people who have gotten very ill. And even if you're in a lower risk category, you're not immune. There's no predicting who may or may not have severe disease. You're certainly at lower risk. But if you even get a minor infection, you think it's not a big deal, you could spread that potentially to someone else. And you could harm your parents, you could harm a coworker, you could harm a loved one, you could harm somebody in this community. So you really need to take the precautions. We're all in this together. We all need to wear masks. We all need to socially distance. We need to follow the guidelines. And I know we all want to open up. We all want to get back to life as usual. The economy is needing that. A lot of people are struggling, but we have to do it in a safe way. And I think that's the big point.
Yeah, I mean, I do always fall back on that. We don't dictate the timeline. The virus dictates the timeline. And so we have to be data-driven in our decision-making. We have to look at what is occurring, the facts, and react to those, right? And so the virus is dictating the timeline. We have to respond to that timeline. We can affect the timeline. We can affect some of that by our tactics and our interactions and how we do this. And we've seen that. But really, we don't get to make those decisions unilaterally. The virus has a say in that as well. It's dictating the timeline.
Thank you, Dr. McDermott. And one of the things that many people have commented on is you see on the news people going back to beaches or thinking about going to a casino or someplace else, and they're talking about this concept of new normal. And you called it something different, as the new different. Can you talk about what that means?
One of our board trustees used that term. Instead of everybody's talking about what's the new normal, what's the new normal, and I think it's a little too early to predict what the next normal will be. We're in a period of different, and so we have a lot of new different going on as we learn more, right? And so I wouldn't predict to know what the future looks like a year from now, and what that'll be. But we're in a time period now where, as we learn more, things will continue to be different, I believe. As we learn more and we get more confident about things we can and can't do, we'll be able to change and be different. But so I think we got to get a little comfortable with this idea that we need to be flexible and adaptable, and recognize that we don't have a new normal as of today. There's still a lot of different and change to come, I believe, and it'll become clearer as we learn more and as time passes.
Yeah, it appears the virus is mostly being transmitted through the air, through droplets. We initially thought it was more likely to be touching a surface, and that still could be a transmission point. But most of the cases that we're seeing appear to be air transmission. So when I look at things, I look at what's the risk. And being outside is a much less risk of being inside. Being in a crowd is still going to be a very high risk. When I look at places of worship opening up, singing within a closed space, that's a very, very high risk. We've seen choirs devastated where multiple members have died. So these are the things as local officials and local business owners, clergy begin to open up, you have to look at the risks based upon the data and adapt accordingly. It's not that we have to stay closed forever, but we have to do things in a safe manner. I've seen certain communities open up or block off certain streets, so restaurants could operate outdoors in a safer fashion. Places of worship having outdoor services to be a safer environment. And when you are indoors, at a mall, at the grocery store, wear a mask. This is a respiratory infection, and that will protect all of us and allow us to get back to life as normal.
Yeah, certainly. When you look at that epidemiologic data, being outdoors looks to be a lot better than being indoors, right? Some of that has to do with dissipation and airflow and all those sorts of things that happen when you're outdoors. And so that's something to keep in mind. Again, to me, it gets back to that idea of dose and time. And we know there's a certain viral load your body needs to take to become infected with COVID-19. It's not like one viral particle. It's maybe, they believe it's like 1,000 viral particles. And so you can get that in a millisecond. If somebody with COVID-19 sneezes or coughs directly into your face, you could get those particles in 1 second, right? But when you're indoors in a restaurant and somebody has it and you're lingering for hours, you can get that dose over a period of time that you're in that location indoors. And so there are tactics that you can take by limiting your time in places to lower your potential dose and your chance of getting COVID-19. And so that concept of dose and time, being outdoors, dissipated air is a better place to be. These are tactics that we know you can take now to really limit your chances of coming down with COVID-19.
Yeah.
So keep it simple. If you're going to be inside, be socially distant, right?
Yep. And
if
wear
you're
a
gonna,
mask.
and when you're going to be, if you're going to be around other people, particularly when you're inside, wear a mask.
Yep.
And no matter what you're doing, wash your hands. Wash your hands a lot.
And limit your time there if you can.
Yeah.
And we've had a few questions for some clarifications on some of the points you've made already. One of them is wearing a mask for long periods of time potentially detrimental in any way? And do we allow our employees to sometimes remove their masks?
Yeah, I mean, our employees can remove their masks when they eat and those other sort of activities. Is wearing masks for a long time detrimental? I would say no. Like in healthcare, in long procedures, we have masks that are worn for many, many hours continuously at a time, all the time in healthcare. So no, I don't believe that wearing a mask for long periods of time is detrimental in any way. Certainly most of the homemade masks and other things too are different than the N95 masks and other masks which even have a little bit more restricted circulation. But even with those masks, you can have them on for very, very long periods of time without any detrimental effects.
Now, it is an adjustment. So if you're someone that's never worn a mask and you put it on for the first time and you wear glasses, your glasses are going to fog up. And so there is a little bit of an adjustment to get used to wearing the mask. But you're right, wearing it for long periods of time, it's a change. It's doing something different. But any momentary short-term discomfort really means nothing compared to the long-term benefit of what you're doing by wearing the mask when you're around other people.
And we've had a few stories of people saying, hey, I was really sick in November, or I was really sick in February. I had a flu test, I had a strep test, nothing came back as a positive. Could I have had it? And one of the stories actually said, and I got an antibody test recently, and it was negative. Is it, what is the probability that it's accurate? What is the probability I could have had it as far back as November?
Yeah, the preliminary data on these tests, and these are approved through emergency use authorization. Normally the FDA studies a test for a long period of time over many, many patients. These have been rushed a bit to market because we need them urgently now given this pandemic. But the preliminary data on the piece of equipment that we have here and some of the others that have received this approval is pretty good. Its sensitivity and specificity approach 100% if the test is done 14 days after the exposure. There are, I know in other infections, people who don't mount an antibody response even though they've had an illness. So there are people who just don't mount great antibody responses. So it's not ever 100% no that it couldn't be that. But also during that time frame, there are many, many viruses out there that cause very similar symptoms that we don't routinely test for. RSV, metapneumovirus, we mentioned the flu, but there are many other pathogens at that same time. So a lot of people were sick and they're wondering, did they have it? But if they test negative, they probably didn't, as long as it's been enough time from the illness when they had the blood test.
Yeah, I mean, the antibody testing is very complicated in itself, yes. Right? Because there are different types of antibody tests. There's a type of test where if you prick your finger and you put it on a little piece of paper, a rapid diagnostic test, there's a type of antibody test that does that. The sensitivities and specificities of those tests tend to be not as good. The test we're performing here at Mary Washington Healthcare, it requires a blood draw, like you're getting a blood test done. And that test we're running ours is an enzyme-linked immunoabsorbent assay, or an ELISA test. Has much higher accuracy than the finger prick tests, and it's run on a very sophisticated piece of machinery to get the result. And so the sensitivity and specificity of the blood type test that we're performing here is much higher.
And a question came through, are we encouraging staff to get tested if symptomatic, and also are they being tested for antibodies?
Yes, so definitely if they're symptomatic. Our health and wellness, anybody who has symptoms, we're not having come to work. We're having them report to health and wellness, and they're getting tested for COVID to keep all of us safe. We have just begun with the antibody test, testing some of our staff. We started with our emergency room, nurses and associates and physicians, and now we're moving to our intensive care unit, our anesthesiologists, people who worked in the COVID unit. And it's our hope that in the next couple weeks we will test all of our clinical staff. This is voluntary, so it's not a mandatory test for our medical staff or associates, but anybody who wants it, we are testing. We're starting off with our staff before opening this up to the broader public because, again, there's a little bit of education that needs to go around what do we do with the results. This is not, if you have the antibodies, that you should be thinking you're bulletproof and you can go and put yourself in high-risk situations. We're not sure what degree of immunity it confers, or if it does, how long that immunity will last. So that's one thing. It is not something that should be used to return to work, or certainly not a test to do if you think you're actively infected. This is not the test for that. That would be the swab, the diagnostic test we talked about earlier.
And I know the answer to this, so I feel weird asking when I know the answer, but are we already providing antibody tests to the community yet?
No, yeah, we have not opened that up. Although some of the commercial labs like Quest and those have it. So if you are interested, you can probably get that at this point through your primary care doc or an urgent care. But as Mike mentioned, I would strongly caution what test you're getting. The most accurate is the blood test, the ELISA test that Mike spoke about. I think that's important if you want an accurate test.
I'd like to go back to some of the other things we talked about, numbers and some of the safety practices that we had. I think that's all the test questions we're gonna front right now. How long has the longest COVID patient stayed in our hospitals?
I don't know if I could speak to the exact time frame, but it's certainly greater than 3 weeks. We've had patients in here for long periods of time in a critical situation on a ventilator. Many patients have had a very long stay. So we've had some that stay very short periods of time though and do recover fairly quickly and don't require ICU level care. So it is very variable. One rumor that we had all heard earlier is if you come to the hospital and you're tested positive for COVID, they're going to keep you for 14 days against your will. That is not true.
No.
As soon as you're safe to go home, we'll let you go and you can finish out your quarantine at home so you don't get others ill, but we are not detaining those who test positive with COVID. But some people have very serious illness that lasts very long periods of time.
Yeah, I mean, we're only hospitalizing those patients that need hospital care to improve their health outcome. We've had plenty of patients come to our emergency room with symptoms who are well enough to go home, they go home. But we don't hospitalize, we'll only hospitalize patients if they need to be in the hospital to improve their health outcomes.
Yeah.
How concerned are we now that Virginia's numbers are starting to rise again when they were level before this week?
There's lots of, I've looked at some, I see a lot of the state data, all of the state data, and a lot of it needs to be interpreted, right? Because some results come in a delayed fashion. Sometimes there are multiple days reported in a single day because of a delay that might have occurred a day or two before that affected hours worth of data. So everything needs to be kind of normalized and looked at in kind of a broader picture. And you certainly can't follow it day to day and make any sort of assumptions based on a single day's results. And so when you look at the Commonwealth of Virginia, I believe the Commonwealth looks fairly stable as well. Some downward trending on some of the data. Hospitalizations have been relatively stable now for a long period of time when they're normalized. Deaths and other things, again, fairly stable. So I would just encourage everybody, don't look at an individual day's number and think you can make an assumption on something is changing. And again, remember, a day's number for a positive test, that's reflecting people that became infected many days ago to be symptomatic enough to become tested or to be hospitalized. That infection might have occurred actually 10 days prior. So all of that needs to be kept in context when you're looking at the state data.
Yeah, I think it's important to outline the time frame. Most people, after getting exposed, they don't show symptoms until 5 days is usually the earliest. Most people by 8 days, some as long as 14 days. It's a long period of time. So when they look at, oh, we opened up a little bit last week, and are we going to see an onslaught of infections this week? No, it takes 5 to 14 days for those infections to occur, to show up. And then when somebody's usually sick for a couple days before they seek care, and then the test result can take several days to come back. So we won't see the results of opening up now for several weeks from now from the data. But I agree with Mike. I think the numbers have been very flat and stable for the last 6-7 weeks, and maybe slightly trending down now. So we're optimistic.
Great. And we've had a lot of questions about visitation. It feels like there's still some confusion as to what types of visitation we allow, and if we have any intention of changing or loosening the visitation. Eileen, would that be something you could speak to?
Sure. So the last time we were with you, we talked about how we were changing our visitation. So it's now been 2 weeks. So on the inpatient, for those patients that are in the hospital, we're allowing one visitor to be able to come to visit the patient during that hospital stay. The same is true in our emergency departments. Is for anyone that comes into the emergency department, they can bring one visitor with them that can stay with them during the course of their emergency department stay. And similarly, when somebody is in the inpatient, they have that one visitor. In both situations, what we're asking is if the patient then is going to go for testing, that the visitor stay in the patient room or in the ED room while the patient goes for that testing. And so we are allowing that. We are not yet allowing visitors in the outpatient setting, so someone that comes in for an outpatient test or an outpatient procedure. And the reason for that is that what that really sets us up for is people gathering, waiting for their loved one to have the procedure or have the test, a waiting room. And just as you've just heard us talk about, inside, crowd of people close together for an extended period of time, there's that rate and time and dose situation that we're talking about. That's not a good situation. We don't want to put people in that kind of situation at risk. So we haven't opened up the outpatient visitation, and we're particularly being very cautious because we want to make sure that we don't unnecessarily expose anyone. And so limiting it to inpatient in the emergency department. Certainly for those patients that are in a situation at end of life, we want to be as considerate as we can. And so we work with our palliative and hospice consult team to actually review each of those situations. For expectant moms that are coming with us to have their baby, their coach, that one person who can be their one visitor, be with them during their laboring and delivery time, and then be the same person that comes to deliver them after the baby is born. And then certainly in all of our settings, if we have a minor, somebody under the age of 18, we certainly want the legal guardian or parent to be able to be with that child. I think what sometimes makes situations difficult is those times that we might have a patient who maybe is confused, or maybe has a cognitive disability, or needs someone with them, maybe to help with communication, to help keep them calm. On a case-by-case basis, we have to consider those. Again, our primary drive is going to be safety, but sometimes the safest way for us to be able to provide care to patients in those sorts of situations is to make sure that a loved one or a caregiver can be with them. And so what we do is when you come into our facilities, the security guard, somebody at the front door will ask you a number of questions. And if it is one of those situations where it's a sort of an exception or outside of the norm of what we're saying visitation is, then our security guards know to call our nursing supervisor so that if there is an exception that needs to be made, that we can do that. I know it's difficult to not be able to be with your loved one, and every situation can be a little bit different. So we ask you to work with us. We want to do what's best for you and for the patient, but we also want to make sure that we do everything that we can to keep everyone safe.
It's a balancing act, right?
It is.
Right, and we need to balance the risks and the benefits of that, and we know we're still in a time where we need to limit the flow of individuals throughout our facilities for everybody's safety. And so balancing all of those things, I think we're doing a pretty good job of that, making sure everybody can see their loved ones in some way. It's just one of those situations. It's very difficult. It's tough, but I think we're doing a pretty good job of balancing those risks and benefits.
We're certainly trying hard.
Absolutely. We've had a lot of questions as well around the return of some of our favorite people, our volunteers and our students. Can you speak to where we stand right now on volunteers and students?
I know for our students, Kathy Wall, who's our Senior Vice President or Chief Human Resource Officer, is actually working on it with a statewide group that's actually looking at students in all facilities across the Commonwealth and how we can safely bring students back into our facilities. That's something we want very, very much because that's our future workforce. We have a vested interest in giving them a great clinical and educational experience because they become our great associates. So we are working on that, but working with other facilities across the state, so we all do the same thing, that there's some consistency, and we can certainly maximize the safety. For our volunteers, we would love to have the volunteers back tomorrow, but again, it comes down to safety. And one of the things that we are looking at is a number of our volunteer activities. One of them that is very near and dear to my heart because it hugely helps on all of our nursing units, particularly here at Mary Washington Hospital, is our volunteers are the people that discharge patients. When a patient is ready to go home before COVID, it's a volunteer that goes upstairs to pick up the patient and take them down to the front door, to the car, to meet their family member who may be taking them home. That's a huge help to nurses that are up on the floors. Well, we don't have that anymore, and so I know that every nurse at Mary Washington would say, please bring back the volunteers, we need their help. But in order to do that activity, those volunteers all sit in an office together waiting for a call for the next patient that needs to be discharged. Well, there we are again, group of people inside, sitting in a room together in close proximity, can't do it. And so one of the things we're doing now is trying to look at what are the things that we have volunteers do and how might we be able to do them differently so we don't place them at risk. So I'd love to tell you we know an exact date when we'll want that the volunteers come back. I can't tell you that, but I can tell you that we miss them greatly, and we're trying to work through how can we do some things differently so that we can bring them back into our facilities. It's not the same without you.
Thank you. And one of our viewers has asked is if it's safe for her 86-year-old husband to have an abdominal procedure, if there's any way she'd be able to stay with him as he recovers, and are we requiring tests for any high-risk procedures for those folks who are already in the hospital?
I think we answered all of that already, right? It is safe to have an abdominal procedure done if you need that to improve a health outcome. We do allow one loved one visitor to be there through the whole course of care, with some limitations on time of day, but you can be here with your loved one while they're hospitalized for that. And then if they do come in an elective fashion, there will be some screening that's done ahead of time before that procedure is scheduled and performed. But the answer is yes. It is safe to have that done.
And only time for just a couple more questions here. One of our viewers is asking, are there any accurate studies yet to indicate population spread? And whether or not there is, I know you've spoken to it a little bit, but are we seeing any sense of immunity? Or is it too soon?
Yeah, I think it's very soon to be speaking about that. There are not a lot of great studies. This has only been a few months, and true scientific methods, scientific studies take long periods of time and analysis. So we're left with anecdote. We're left with talking to other colleagues at other institutions who may have preceded us for a few weeks, like talking to those in Washington State and New York, which we've done, and New Jersey, to try to learn. There's great communication amongst the healthcare community on new treatments like remdesivir and convalescent serum, but not studies. When we look at prevalence in communities, there's some initial data on that. When we look at antibody studies of groups of people, it tends to be on the level of 2 to 3% in most regions of the country. A very high dense population that had a catastrophic degree of disease, like Manhattan, had upwards of 15 to 16%. I'm fearful that none of that confers herd immunity at this point. It's hard to say how many people need to be infected or carry antibodies to say you have herd immunity. For many other viruses, it can be as high as 70%. So it's difficult to say, but I don't think we're at a herd immunity level. But this is a new virus, and there's still so much we're learning about it. We don't know if there's seasonality to this. It's an RNA virus, which makes it more prone to mutation. We don't know if it'll mutate. We don't know how long immunity, if you have had COVID or you get a vaccine down the road, how long it will last. Right. So I wish we had more evidence of some of these things, but we're learning as we go. Every day we're learning.
Thank you. One last question. One of our viewers noted that Virginia seems to have a higher 100,000 per 100,000 exposure than states such as Texas, who has had longer relaxed guidelines. Is there any reason to really point out why one state might be more affected than another?
Well, I can imagine that the data reporting from state to state can have some variations based on what they're counting and how they count it and when they count it. So I'm not sure we have exact apples to apples to apples when we look at all of the state data that's coming, being coordinated by the states individually. There's going to naturally be some variations there. So I can't specifically answer that per 100,000. Is that a prevalence number? I'm not sure I quite understand that. But when you compare Virginia data to Texas data to Georgia data to Ohio data, I think they're all kind of separate pools of data, and you need to know everything about what's being put into those data sets to understand them. I don't think they're interchangeable, I think is the best. I don't think they're interchangeable.
Yeah, and there's so many more variables than how open the society is, population density, people traveling, commuting, spreading, vectors of disease, age.
Comorbidities.
Yeah, there's just so much more to it than whether, it's been more lax in opening than not. So I wouldn't read too much into that.
Yeah.
Thank you. So I think that's wrapped up our questions. So I'd like to go to each of you to give some closing thoughts. I'm going to actually start with you, Eileen.
Well, I think I'll build on what Mike said, is that our new different. And so hopefully tonight what you can take away from what we've been sharing with you is we're safe. It's safe to come to get health care. We're concerned because maybe people aren't getting some of the basic screening things that they should get, or the basic things that they would normally do to keep themselves safe, like seeing their physician, getting prescriptions filled, doing follow-up on medical issues. And that, as Chris said earlier, can have catastrophic impact, and we don't want people to do that. So I ask you to please be mindful of your own personal health. And if you've got those screening procedures that are due to happen, if you're due a visit to your primary care physician, please do that. Please take care of yourself. It is safe to receive health care, and it is not safe to postpone health care at the risk of your own personal health. So please take care of yourselves. And remember, if you're inside, no crowds, wear a mask, wash your hands, and keep moving around.
Dr. Newman.
Yeah, I think when there's a lot of uncertainty, as we've all been facing over the last 3 months, there's a lot of fear that can sometimes go with that, and we don't want people making irrational decisions. So, I feel privileged that we're able to do this every couple weeks so that we can share the data, and at least with the best data that we have available, give advice to how we can proceed. So, at this point, from what we know about this virus, and as society begins opening up, many of us have been hunkered in our homes, working from home, and as things move out, we want to make sure people are safe. So as Eileen said, the healthcare system is very safe. Don't delay other things and put yourself in a bad situation because you're afraid to come to the hospital. So that is very, very important. But for those other than needing healthcare, outside is much safer than inside because of the air circulation and the way this virus spreads. Crowds are a no-no always, so avoid crowds. There are certain activities that are high risk because they shed the virus. Singing, cheering, I think of athletic events. So as we think of things opening up down the road, things that we normally do and don't think about, like singing at a church service or cheering on our kids at the sideline, these are all high-risk situations. So we have to maintain social distancing as some of this opens up. When you can, move some of these activities outdoors, like restaurants and like worshiping services and many other things. We're lucky to live in a beautiful region of the country where we have great weather usually, so that's always safe. And avoid prolonged times in small, closed indoor spaces with the same people, because that's how the disease is really transmitted the most. And always when you're inside, wear a mask. I don't understand a lot of the controversy around it. As we say, wearing a mask is a sign you care for others. This is an airborne droplet disease. You can really prevent transmission. You can keep yourself and others safe by doing this. So follow the governor's order. Yeah.
Thank you. And Dr. McDermott.
I just want to end just by thanking everybody for taking the time to spend a part of your evening with us again. I want to give a shout out to our Mary Washington healthcare team, everybody here who's working so hard every day to keep our community safe and make sure everybody is well cared for. But all of you tuning in, again, just thank you for your time. We're happy to share with you what's going on here in our community, our perspective on COVID-19. But everybody tuning in, and spending this time with us. It shows how much you care about our great community, and we're just very appreciative of you taking the time to spend with us. So thank you.
Thank you all. And on behalf of Mary Washington Healthcare, thank you to our panelists for providing your expertise again this evening. We also appreciate you joining us, those watching online, to learn about COVID-19 in our community and sending in your questions. For the latest local COVID-19 information, stay tuned to the Mary Washington Healthcare Facebook page and visit us online at mwhc.com. Good night.